I'm a dermatologist, and often I'm speaking about dermatology, but I'm also a lab rat, so I'm really thrilled to actually be talking about stuff that we work on in the laboratory, which is circulating tumor DNA. And I'm going to focus exclusively on melanoma. There's really not much in this area for the other skin cancers. These are my disclosures, mostly industry relationships with respect to our research. Now, just to get everybody on the same page, cell-free circulating tumor DNA is free-floating in the plasma, released primarily from apoptotic or necrotic cells in states of high turnover. Its average length is about 160 base pairs, and it maps to nucleosomal protected DNA that gets released. And we can see increased levels in cancer and inflammatory conditions because those are states of high turnover. And there's some suggestion that also just high proliferative states will have some higher circulating tumor DNA. And it's a promising biomarker in several cancers for the blood-based detection of solid tumor mutations, also to characterize treatment resistance mutation mechanisms and disease monitoring. And I just want to remind you, I will not be talking about circulating tumor cells. That's another area of what you can look for in the bloodstream, but that's not as advanced in melanoma, so I'll be focused on circulating tumor DNA. So it's really moving quite rapidly, I would say, in many cancer types. I just want to give you two examples outside of melanoma. In metastatic non-small cell lung cancer, the concept of liquid biopsy, which is basically taking a blood test to figure out what's going on in a solid tumor without actually getting the tissue. There's actually an FDA-cleared ctDNA test, circulating tumor DNA test, using plasma to identify patients with EGFR mutated tumors. And this can aid in the decision to treat with erlotinib first line. So you know the patient has the mutation in their tumor even without the tissue biopsy, and you can go ahead and use erlotinib. If the test is negative, which it can be, it's about an 80% sensitivity, generally speaking, you reflex to a tissue-based test, and that patient needs to go for a lung biopsy. But really, for patients who are too ill or unable to provide tissue sample for mutation testing, this is really a very good option. Now, I would suggest that in colon cancer, things might even be further along in terms of minimal residual disease detection. Now, in contrast to lung, where you're taking this test and you're looking for a particular mutation, you don't know what's in the tissue. In minimal residual disease detection, you have the tumor, so you can sequence the tumor and figure out what mutation is there, and then track that mutation in the bloodstream. So both in resected stage 2 and 3 disease, it's been found that postoperative detection of this mutated DNA is associated with relapse. And if you look in stage 2, the hazard ratio is 18, which is absolutely astounding, and that patients who had detectable ctDNA after resection of stage 2 colon cancer went on to relapse versus those who did not. And in stage 3, it was an independent predictor of worse recurrence-free interval. You can see also a very strong hazard ratio of 7.5. So now in Australia and New Zealand, they're doing randomized clinical trials to look at how ctDNA can inform patient management. In stage 3, they're either going to basically adjust the adjuvant therapy for these patients to more intensive therapy if their ctDNA was positive versus less intensity if it was negative. And in stage 2, since adjuvant therapy is not standard, patients who have detectable ctDNA will be randomized to adjuvant therapy or not. And we await the results of these very exciting trials. Now, in melanoma, people often ask me, well, can you use this to diagnose a melanoma? You know, I'm a dermatologist. My dermatology colleagues ask me this, and what I want to point out is that you need to have a certain amount of tumor in the patient in order to actually detect circulating tumor DNA. So we're really focusing on patients with lymphatic metastases or distant stage 4 metastatic disease. Now, we know the current paradigm for monitoring patients is CT scans every 3 to 6 months, and that's because our blood test, LDH, while very good to stratify patients prior to treatment, it's incorporated into the staging criteria, it lacks sensitivity and specificity to really be used as a monitoring test. So potential uses for ctDNA in melanoma, it can be a A liquid biopsy to identify BRAF mutant tumors. Now, it turns out most oncologists I talk to say, well, we have no trouble really getting tumor, so that's not really such a great application. And I said, okay, fine, no problem, but we can do that if we had to. More likely disease monitoring, which I'll get into, and also aiding in the interpretation of ambiguous radiographic results. I'll talk a little bit about that. Prognostication in resected disease. When you resect a metastatic disease, can we figure out who's been cured by that or who has minimal residual disease not yet detectable, and make a prediction. As well, prediction of treatment effects, and we'll go into that a little bit. And then finally, where are we with using ctDNA to guide treatment decisions? Now, I'll be talking a lot about droplet digital PCR. That's the method that we use in our laboratory, but also many others around the world are using this. It's a very highly sensitive and specific method to actually measure the amount of DNA in the plasma. There are other methods used in terms of sequencing, but most people are using droplet digital PCR. Now, one of the limitations of droplet digital PCR is that you can only look at a few mutations at a time, really only one or two perhaps per assay, whereas sequencing-based techniques can look at multiple markers. But in melanoma, we're fortunate because common hotspot mutations facilitate ctDNA measurement. So what am I talking about? Well, it turns out BRAF V600 mutations, along with NRAS Q61, and two mutations in the TERT promoter region can be found in about 88% of metastatic melanoma patients, and this is from a paper we have in press at the Journal of Investigative Dermatology. And in this study of 99 patients, we found that BRAF mutations were present in about 39%, NRAS in 21%, and you all may know that those are typically mutually exclusive in almost all cases, so that gets you up to about 60%. And then these two TERT promoter mutations, which regulate the transcription of the telomerase reverse transcriptase gene, are also typically mutually exclusive, and each one was present in about 35% of patients, so that's 70% right there. Now, some of these co-occur with BRAF and NRAS, but about 2/3 occur on their own, so you put it all together, and about 88% of patients have a mutation that we could measure using assays for these mutations. And that's what we've done in our lab. We've developed and analytically validated 7 droplet digital PCR assays. We actually helped to develop the TERT assays with Bio-Rad. And what you can see here on the left side is just an example of analytical sensitivity showing that these assays measure what you expect them to measure. As you increase the amount of DNA in the sample, they go up in a nice linear way. And most importantly, for what we're doing with minimal residual disease detection, in the middle was an analysis of 30 healthy donors to find out what's the background level in an otherwise healthy person, so we could come up with a really robust cutoff value. And you can see on the right, those are in very, very low mutant copies per mil. We typically use 5 mils of blood, so about anywhere from 1 to maybe 8 copies in a tube of blood. Now, just some examples from our lab in terms of monitoring disease activity, but there are other studies being done in other centers around the world. This was a pilot study of 31 patients, unresectable disease, who were getting various treatments. And what we found was that in just looking at BRAF and NRAS at the time, the TERT assays weren't developed at that point, we had an 80% detection rate in terms of finding the mutation in the blood. And then at disease progression, ctDNA was elevated in 82% of patients, whereas LDH was only elevated in 40% of patients, showing it had a higher sensitivity to detect disease progression. Now, if I can use the pointer here, maybe. Here on the, not using the pointer. Yeah, okay, so this is a graph showing a patient's disease course. The red line is their RECIST score, and you can see they're on BRAF/MEK treatment, and they're showing a fairly decent response here. The blue line is the circulating tumor DNA, which became undetectable at about day 40, but then started to increase at about day 90, and then continued to increase here, along with their RECIST score. But I would say before we saw a big change here, we saw an increase in ctDNA, and LDH in gold did not rise above normal. And there's a similar pattern here. Again, ctDNA in blue rising prior to this patient's disease progression, which was flagged here, this dotted line. That was actually brain met that the patient developed. LDH really lagging here, and a small increase in their RECIST. Now, we had leftover sample, so we looked for NRAS mutations, which are known resistance mutations to BRAF-targeted therapy, and this was a poster we presented at AACR, and you can see here at this time point, after the patient had one course of BRAF inhibitor monotherapy, we were able to detect NRAS mutations at 34 copies per ml, and the patient went on to another BRAF inhibitor, but failed that quite quickly, perhaps due to the presence of NRAS-mutated tumors that had arisen. And similarly, another patient, we detected NRAS-mutated DNA in the plasma while they were on BRAF therapy, and they were failing that therapy. And there are others who have done similar analyses Now, with respect to interpretation of radiographic results, there's a study from Australia looking at the distinguishing pseudo-progression from progression. This was 29 patients who had progressed on anti-PD-1 therapy. 9 of them were determined to be pseudo-progression because they had a favorable DNA profile. They had either undetectable ctDNA or it was detectable and then went to undetectable. And 7 of those 9 patients were alive with a median follow-up of 110 weeks. The group from Evan Lipson down at Johns Hopkins also looked at radiographic correlation with ctDNA, and in 8 out of 8 patients that they were following with progressive disease on various systemic therapies, all 8 had detectable ctDNA at the time of progression, and 4 of them, the ctDNA had predicted the radiographic disease progression by an average of 21 weeks with a range from 8 to 38 weeks. Now, what about as a prognostic marker in resected disease? You may remember the AVAST-M trial. It was unfortunately a failed therapeutic trial, but this was resected stage 2 in 3 patients, and they were randomized to bevacizumab for a year versus observation. Bevacizumab had marginal benefit with disease-free interval, but no OS benefit. But we were interested in the analysis they performed on the postoperative ctDNA. They looked at BRAF and NRAS in the plasma and detected it in only 12% of patients, but it was an independent predictor of worse outcome. You can see with a hazard ratio of 3.3 and an overall survival hazard ratio of 2.5. Suggesting that if you can detect DNA in the plasma of these patients after resection, they're really going to do poorly. Now, a separate study of stage 3 BC patients, of a cohort of 52 patients, found 25% of the patients had detectable ctDNA after resection, and this was 13 patients, and all 13 relapsed with a median time to relapse of 3.5 months, and again, a very strong hazard ratio of 10, and it was associated with distant metastatic disease, meaning these patients had microscopic residual disease that was not detectable but on scans, but was detectable in the blood. Now, if you look at the patients who were ctDNA negative post-op, it turns out that actually 41% of them did relapse, so this is not a perfectly good test, but their median time to relapse was 13.5 months, meaning that they probably had such low levels of microscopic residual disease it wasn't able to be picked up by the test. Now, one approach to try to improve this would be to look at serial measurements, and that's what we're doing in collaboration with Bristol Myers. We're looking at patients who were in the Checkmate 238 study, and in addition to looking at how the detection of ctDNA can relate to survival parameters, we're also evaluating it as a diagnostic test at each time point in which samples were collected, roughly every 3 months. And you can see in that table this different sort of scenario how to evaluate ctDNA as a potential diagnostic test. If the ctDNA was positive on a follow-up visit, and the radiographic scan was positive, then the ctDNA was a true positive test, radiographic scan, of course, being the gold standard. And if ctDNA is positive before the scan is positive, that would also be a true positive for ctDNA. If it was positive but the scan never showed anything, that would be a false positive test. True negatives are obvious. And a false negative would be if they progressed on scan but we didn't detect it in the blood. So hopefully in about a year or so, we'll have some results to share with you on this analysis. Now, what about as a predictive marker with treatment? So the typical analyses are looking at baseline ctDNA detection or on-treatment ctDNA detection to determine can we predict how the patient is doing and maybe have an early indication that they should have their treatment modified. And these have been various studies, generally small case series with different methods to detect BRAF, for example, and these assay sensitivities range from 53 to 91%. So we were fortunate to have a collaboration with Novartis to study this question as a ctDNA for BRAF V600 mutations as a predictive biomarker for BRAF targeted therapy. We analyzed patients from COMBI-D, which you may recall was a randomized phase 3 trial that led to the FDA approval of dabrafenib and trametinib for unresectable and metastatic melanoma. And we used our analytically validated droplet digital PCR assays for either V600E or V600K, and the tumor mutation type was provided to us by Novartis. And our questions were whether higher levels of pretreatment ctDNA predicted worse survival, and whether on-treatment ctDNA levels predicted survival outcomes. And we had available to us only one on-treatment measurement, and that was at week 4. So this was the first large-scale study of ctDNA analysis in patients treated with targeted therapy using an analytically validated ddPCR method, and we presented this at ASCO last year. Just to give you a feel for some of the data, here's some example patients. You can see patient 1, baseline, they have a mutant allele fraction of 30%, meaning 30% of the DNA in their plasma had the BRAF mutation in it, and then at week 4 they had a sort of molecular complete response. They had no detectable mutated DNA. Patient 2 started off with a lower level but was unable to clear. They had 2% residual DNA at week 4, and patient 3 had an astoundingly high fraction of 70% of their DNA in the plasma had a BRAF mutation, and although they had a very striking response, they still had 5% at week 4. What we found overall was that we could detect ctDNA in 93% of baseline samples, so sort of as a liquid biopsy, if that was of interest. 93% of the patients were positive in the plasma. And 60% were still positive at week 4, but you can see a very striking decline between the initial values and the week 4 values. And also you can see this, I'm not sure how well it shows, but that's the copies per mil is really covering 4 logs of value. So it's a very dynamic range here. Now, V600 ctDNA was associated with clinical outcomes at baseline, higher levels associated with worse outcomes as a continuous variable because we have a really quantitative measure, and that was for either an unstratified analysis or stratified analysis. Basically, the more you had at baseline, the worse the survival. And then in the on-treatment, we had the one measurement at 4 weeks. We looked at what's called zero conversion, going from detectable pretreatment to undetectable. And if you could become undetectable, you had nearly doubling of your survival. Median PFS was nearly 13 months if you went to 0 at 4 weeks versus 7 months if you had residual DNA detected with a hazard ratio of 0.55, I think pretty respectable. And also, like for OS, they're doubling of their survival if they cleared their DNA at 4 weeks. And this also included patients with elevated LDH. You can see in this Kaplan Meier curve, as Jeff likes to say, you'd like to be on the purple curve as opposed to the gold curve. And the purple curve is if you cleared your DNA at 4 weeks. There's the gold curve, you had residual detected DNA. And the median OS there also doubled from about 11 months to a little less than 22 months. And that was significant. Finally, what about immunotherapy in response to PD-1? This is a study from Australia, and I'll take you through it on the left side, the Kaplan Meier. The top curve, which is in green, is patients corresponding to the top chart on the right. This is sort of group 1, or group A they call it. And these were patients who had undetectable levels at baseline, shown in the green. Let's see if I can point to this here without dropping the clicker. So here at baseline, green means that they could not detect their DNA. Blue are missing data points. But they stayed green throughout the entire baseline up to 12 weeks of treatment, and they had the best survival. Group B here had a little bit worse survival. That's this group down here. You can see they had detectable levels in the pink, but then they converted to undetectable levels by 12 weeks, in most cases by actually 5 or 6 weeks, and they had not as good but better survival than the patients who had detectable levels at baseline and remained detectable during treatment, and they had very poor survival here. So you can imagine potentially using this to help inform potentially modifying your treatment early on, and we're starting to explore ways to do that. Finally, there's actually a group that is doing this in Manchester. They have the Cactus trial, and their goals were whether the efficacy of immune therapy could be enhanced by response to pretreatment with MAP kinase pathway inhibition. And so just as a general question, should you treat with BRAF/MEK first and then switch to immunotherapy? And then whether ctDNA levels can be used to inform when to switch. So they are doing a pilot study of 40 patients where they're going to give them dabrafenib and trametinib and switch them to ipi/nivo after an 80% or higher decrease in circulating tumor DNA. So not getting to zero, but just an 80% reduction. And actually, I don't know how they came up with that number, but they are using it, versus the other arm where they get switched at clinical progression. So hopefully in the next year, they'll be reporting that out. So in conclusion, I think conservatively we can say more than 85% of melanoma patients have hotspot mutations that can be tracked in their plasma. In unresectable metastatic disease, ctDNA measurements prior to treatment and during treatment are associated with survival outcomes. In resected stage 3-4, who are radiographically NED, post-resection ctDNA measurements may indicate microscopic residual disease and may predict survival outcomes. ctDNA monitoring shows promise as a predictive and prognostic biomarker for melanoma, and on-treatment monitoring may eventually inform clinical decision-making. Hopefully, Jeff is quite optimistic in the next 3 years. We're certainly working towards that. I'd like to acknowledge the people in my lab who have been doing all this wonderful work, as well as my colleagues at NYU in the melanoma program on the clinical side, as well as my industry collaborators, who are many. And I want to thank USA taxpayers for your support through grant dollars, as well as other support. And thanks very much for your attention.